So here today we will be learning about the coronary circulation, physiology of coronary circulation, physiological anatomy of coronary circulation, and its peculiarities or specialities or important features of coronary circulation that we will be learning. And we will also be learning its some applied aspect of coronary circulation. Though heart is pumping, it's having a lot of blood in its cavity, but it cannot directly use it. Why? The wall is thick. This blood cannot diffuse into inside. So that's why they need special circulation in the wall of in the myocardium of the heart. So this circulation is called coronary circulation. So it will be having, since it is a circulatory process, it will be having arterial system, it will be venous system, and sometimes excess fluid may remain within the tissue space. So that has to be evacuated, and that is done by the lymphatic system. So they drain these lymphs not into the cavity of the heart, but into the lymph glands. Okay. And the main arteries of the coronary circulation, main arteries, it will be having smaller arteries, arterioles, capillaries. So main arterioles, arteries remain on the surface of the heart. Means in the epicardial outermost layer, there are three layers: epicardium, myocardium, then endocardium. So in the larger arteries, coronary arteries, they lie in epicardium. That's why we call it superficial arteries. From them, from the superficial arteries, branches are produced. They penetrate into the myocardium, and there it supplies the myocardium. But the innermost layer, this is the critical part. Innermost layer is very critical part. Why it is critical part? We will learn why it is critical part. So that's why this part has made some adjustment. Where the innermost layer facing the cavity of the heart. So about it is 10 millimeter of the innermost layer. So they can directly take their oxygen, nutrients from the cavity. Okay, so that part is only this much layer, this much part of the myocardium or the wall of the heart, they can get directly their nutrients and oxygen from there. But it is very minuscule, means very less in comparison of the whole requirement, total requirement. It is very, very less. So the heart cannot depend on that. See the wall. So these are the main. This is the main coronary artery. From it, branches are produced. Some are going. These are the arterioles or smaller arteries. They penetrate into the myocardium. Okay. This is the subendocardial layer. So in the subendocardial layer, some smaller arterioles are combined. They combine. I already told you this layer is very much susceptible. Very much. That's why the anatomical system or physiological system has been modified so that it doesn't face so much difficulty. Some arrangement is made so that it can, even during difficulty, it can get the adequate amount of oxygen and nutrients. Okay, so the joining of the smaller arteries, very small arterioles, so they joined and form a subendocardial arterial plexus. So plexus means what? What do you mean by plexus?
Group of the arteries.
Group of arteries. Group of arteries lying together. Okay. it may happen, this sort of plexus also we can get in our system. Here, a group of axons may run together, may lie together, okay, and perform particular functions. We have seen imaginary in muscular layer of GI tract. So in between the longitudinal layer and the circular layer, circular layer, there is one plexus, mesenteric plexus. Also, there is another plexus in the innermost layer. Okay, so we have discussed about this in our earlier classes. So plexuses may be of two types: the neural plexus and this type of plexus, subendocardial arterial plexus. Small coronary arteries are the principal. See, why I have given emphasis. See, larger arteries that remain in the epicardium, that are low resistance. Without resistance, very small resistance. So blood can flow easily. But the smaller coronary arteries that are penetrating within the myocardium, tell me, what will happen? This is my bicep muscle. Some vessels are running through it. Now, if I contract these muscles, what will happen to these vessels? They will be compressed, isn't it? They will be, since the muscle is squeezed, compressed, the blood vessels will also be compressed. So, flow of blood will be ceased or reduced. Same thing can happen when the wall is contracted, muscles are contracted. What will happen to these vessels? They will be compressed. So less blood will be flowing to this. So myocardium will suffer hypoxia. Myocardium may suffer hypoxia. When hypoxia is produced, then what happens? There we feel pain sensation. We feel angina pectoris. But always in normal cases it doesn't happen. During muscle contraction of the myocardium, the flow will be reduced. So the heart will try to manage this so that flow is maintained. Though it is constricted, flow is maintained. We will discuss. That's why this part is very important. And this part is more important. And this area, subendocardial area, or this layer, innermost layer, they actually suffer most deficiency of oxygen or deficiency of nutrients. The coronary circulation consists of arterial blood supply, venous blood supply, as I said, and lymphatic drainage. The arterial supply is made by two arteries. What are these? Left coronary artery and right coronary artery. From the term itself, it defines the left coronary artery will supply blood to the left side, mainly to the left side of the heart, and the right coronary artery will be supplying blood mainly to the right side of the heart. But there is some branches of right coronary artery may supply the left part, some part of left part may supply the right part. That is also will happen. So from where they arise? Where is the origin of these two arteries, left and right coronary arteries? So there is aorta. Aortic arch. So aorta has got an origin. So this origin, the base of the aorta, it is the root of the aorta. From the root of the aorta, both the arteries originate. And the base of the aorta, root of the aorta, they are having also some valves. These valves are semilunar valves. And these semilunar valves, there are three cusps Three cup is there. Within the cup there is sinus. Like cup, there is a cavity within this. So this is called the sinus. So three cup is having three sinus. From the back of this cup, okay, so there, when they open, they remain like this. When the valves are closed, they remain like this. So suppose this is the aorta, so they remain 1, 2, and 3. Okay, so when they open, what happens? It opens like this because blood is coming through this side, so they will be pushed. When they are pushed, the cusp will be moved like this, and at the back of the cusp, there are the orifice for the right coronary artery and the left coronary artery. So during systole, when blood is injected into the aorta, this cusp opens and partially covers the orifice of the both arteries. Okay, so as a result, during systole of the heart, much blood cannot enter within the arteries. This is one reason. This is a partial reason why during systole of the heart, cardiac muscle get less blood. There are another reason. What is the another reason? During systole, what happens? Blood is coming out of the ventricle, heart is squeezing, so that the blood that is coming through the arteries, they tend to enter within the myometrium, but myometrium is squeezed, so they cannot enter. That is another cause of what? Decreased coronary blood flow into the myometrium during contraction. What do you think? Coronary myometrium, ventricular muscles, whether they will be getting, when they will be getting more blood supply through the coronary artery, whether during systole or diastole. This is the ventricle. This is the ventricle. Okay. And here is the root aorta. And coronary artery coming out from here and here. This is going to the right side and this is going to the left. Sorry, this is going to the right side and this is going to the left side. And they are supplying the various organs, various parts also to the ventricles. Now what happens? Ventricle contracted, blood came out, entered into the aorta. So since these two vessels are outside the valves, at the root of and the pores are from there, origin is from there, more blood supposed to enter within the arteries, firstly cannot enter. Why? The flap is closing the opening. When the flaps are open during systole, they are covering the pores through which they are covering the orifice of the both arteries. This is number one. Second one, so they will be trying to flow throughout the wall, but the wall is squeezed now during systole. Can it enter within this? So actually during systole, blood flow is reduced it's unlike other organs. In any other organ, any other part of our body, during the tissue gets more blood during systole and less blood during diastole. But it is reverse in case of coronary circulation. Why it gets less blood during systole? Why? What is the reason? Two reasons. One is during systole, adequate amount of blood cannot enter within the coronary circulation. Why? Because flap is partially closing the opening. Secondly, the ventricular muscles are squeezed, so blood cannot enter through these vessels. As a result, blood flow is reduced during systole. But opposite happens during diastole. During diastole, the wall is relaxed and valves are closed now we know why we hear the second hour sound. Why we hear the second hour sound? When ventricle is pumped, is contracted, blood is ejected into the aorta. Now ventricle is going to dilate, relax, diastole. So this blood will try to come back, cannot enter, because this aortic blood will try to enter, and if while trying to enter within this, valve will be closing. So now because of this aortic blood pressure, more blood will be entering into the both arteries, left and right arteries. And since diastole, these are not constricted, more blood can pass through the vessels. So that's why during diastole, coronary blood flow is more during diastole. Is that clear to you? In semilunar valve, there is no chordae tendineae and
papillary muscles.
Papillary muscles. These are not there. Why it is there in bicuspid and tricuspid valve?
Because they are the part of the myocardium itself.
No. Why it is necessary?
Because it can contract and repeat.
Why it is necessary? When ventricle will be contracting, what will happen? This ventricle, the blood, content of the blood will try to enter again into the atrium. So that should be prevented. How it is prevented? Now this valve, bicuspid and tricuspid valve, because of the pressure, they will try to open. This will try to open, but these ligaments, papillary muscle and chordae tendineae, that will prevent outbulging of the valves. If it outbulges, then there will be opening. Through this opening, blood can again enter into the atrium, and it may produce regurgitation. But it is not wanted. This is a disease only. It happens only in case of disease, either because of tearing of the chordae tendineae or paralysis of the papillary muscle, or because of the disease of the leaflets. The disease of the leaflets itself. What may be the disease of the leaflet? It may become thick. Why thick? There may be deposition of calcium. So it will be thick, heavier, and one part may remain normal, but other part may remain abnormal. So as there are normal closing of both will not be at the same time. As a result, some gap will be there, regurgitation will be there. So you can see this. What is this? Suppose this is the aorta, this is the root. So I made a longitudinal section. I slitted it. So, and then made it apart. So how it will look? This will look like this. So at the back of this valve and this valve, there is aperture. That is the opening of the left and right coronary artery. So where it is located? This is the sinus of the valve. And these are present at the root of the aorta, not below this, over this. So when the flap opens because of flow of blood into the aorta, they will close like this, and they may partially cover this. So there will not be easy flow of blood into this will be prevented. Left coronary artery, right coronary artery. See, when they remain closed, the blood within the aorta, they tend to enter. Blood, when the ventricle undergoes diastole, so what will it will be closed. Why? Because of the pressure. Okay, this because of the pressure, and because of this arterial blood pressure, blood will enter through this. Okay. See, when this is opened, what happens? The flap is closing the opening, almost closing the opening. This is the right coronary artery. it remains in epicardium, superficial layer. It runs between, this is what? This part is what? Auricle. Right, this part is auricle. Auricle is what? Extension. So in between this part and this is the pulmonary trunk. So in between this area, the right coronary artery originating from this is the root of the aorta. So from this it is originating and passing in between and passing through, there is a group, coronary sulcus. So it will pass through the coronary sulcus. While passing through the coronary sulcus, it will produce several branches. Where these branches will go? See, where this branch, where it will go? SA node. The first branch is going to SA node. Then this branch, it is going to this area. What is this area? Conus area. This is conus area, and one branch will go to the conus area, and then another branch will go to the arterial branch. This branch will mainly supply blood to the which atrium? Right atrium, and partly to the left atrium, mainly to the right atrium. Okay, so that's why it is called right atrial branch. Then the right coronary artery will give branch to this branch. What is this? Right anterior ventricular branch. Right anterior ventricular muscle, right atrium, right ventricle, anterior wall. So that part will get blood supply from this. Again, after that, it will produce two branches. One will be going to the back side along the group. Same sulcus at the back, posterior side sulcus is going at the back. So following the same sulcus, it will be going to the back side. So it has turned to the back. Okay, it is a turn to the back, and it has produced what? PDA. This is very important. Most commonly, this part is affected or develop atherosclerosis. So this PDA, and this is the right marginal branch. So it passes along the margin, anterior posterior margin of the ventricles. So margin. Then it will go backward, and there it will form PDA. Okay. Now see, this is about the right coronary artery and its branching. Let's see. These are the branches. Now see. The anterior segment. What are the branches from beginning? SA nodal artery. Second, right conus artery. Third, right anterior ventricular artery. And then right marginal artery. And then atrial branch. Okay. Now this anterior the right coronary artery is going to the back, turning to the back. So at the back, what branches is there? These are giving two main branches: right posterior ventricular branch, then posterior. This one PDA is another important artery from which is mostly affected. More commonly affected means atherosclerosis is made. Okay, so that's why PDA is in echocardiography report you will find, or angiography, PDA intact or blockage in PDA, or other one is another important branch we will get in left coronary artery. That is LAD, left descending artery. Posteriorly, left descending artery posteriorly. So this will be in the posterior side, the PDA will give branches to the AV node and also to the septum. Septum means intraventricular septum or IVS. In short, IVS. Okay. So you learn about this. Okay. Fine. So which part, the area of RCA distribution, which part will be of the heart will be distributed by the right coronary artery. Let's say we have seen SA node is supplied by them, AB node is supplied them, complete right atrium and part of the left atrium. And intraventricular interatrial septum IAS, it is supplied by this artery RCA, and small portion of LV posteriorly. Okay, and posterior 1/3 of the IBS, posterior 1/3, and rest 2/3 will be supplied by the left coronary artery. And the whole conducting system, what are we have seen SA node, AV node already it supplies. What are the other bundle of fish? Right bundle branch, left bundle branch, Purkinje fibers. Okay, these are the other conducting system. These are supplied by, except LVB, because LVB is supplied by both. Left bundle branch is supplied by both the arteries, but other part is supplied by the mainly right coronary artery. Is that clear to you? Right? Okay. Now let us look upon the left coronary artery. So it originates from right coronary. It is larger than the right one. It is larger, bigger inside. It originates from late posterior aortic sinus, this valve. Okay. The trunk of the artery appears between the pulmonary, we have already told you. Anterior, it will produce two branches, anterior interventricular artery and circumflex artery. Circumflex artery means the part of the left coronary artery which is going to the back. Okay, that is the circumflex. And I forgot to tell, coronary artery, corona. Why this term has been given? Corona means crown. Crown. So coronary circulation is having crown-like structures that going through the sulcus and circling the heart. That's why, and from this, the branches are coming out, forming the crown. Okay, that's why the coronary circulation name is given to it. Now see the left coronary artery. Why this part is dotted? This is the aorta, and here is, if you look at from anterior side, so first the vessel you will find pulmonary artery. Then behind this we will find the aorta. So here is what? Pulmonary artery. So this branch actually coming from the back of the coronary artery. That's why these are dotted. It is from the back. From the back, it is by rotating or encircling this pulmonary artery, it is coming anteriorly. It is coming to the anterior aspect. Then it is producing two parts. One is going to the back, another is descending down towards the apex of the. But this part is the left ventricle, so going to the left ventricle. Okay, and another part it is giving mostly covering the left ventricle from the back. Okay, so what are the branches? What are the branches? First one, the branch that is going to the back, circumflex artery, left circumflex artery, LCX. It is abbreviated as LCX. That means left C for circumflex artery, LCX. So it will be producing LCX, and this one, left anterior descending artery, that will pass through the interventricular sulcus. Within two ventricles, there is within the two ventricles superficially, there is a sulcus. so it will pass along this circus. So this is the branches of the left coronary artery. So what are the branches? First is left anterior descending artery already, then left circumflex artery. From the left circumflex artery, the septal artery, left marginal artery, they will be produced. And area of distribution. These are the area distributed in the left coronary artery. And venous drainage, venous system. There are two main venous drainage. One is the superficial venous drainage and the deep venous system. Superficial venous system will not go in detail. There is coronary sinus, great cardiac vein and anterior cardiac vein. Through this vein, the blood is delivered mainly through coronary sinus into the right atrium. And in the deep venous system, there are three main veins: arteriosinocetal veins and arterioluminal vessels and the Thebesian vessels. So these are the main venous vessels, veins that drain the blood into the atrium. Or it may directly these vessels can directly drain their blood directly into their cavities, corresponding cavities. Collaterals. You will get collaterals in the coronary circulation, but it doesn't work. In normal heart, it doesn't work. It becomes functional during emergency. During emergency means if there is narrowing of blood vessels, coronary blood vessels, so there will be angina, means ischemia. So when ischemia starts, difficulty, that is not adequate blood supply, that time collaterals start to form or start to become anatomical collaterals are there. What are collaterals? What do you mean by collaterals? What do you mean by collateral or anastomosis? Joining of vessels. This is also artery, these are also arteries. Both are joining. So this way they are formed collaterals. When these are formed, by chance if one is blocked, then other may become active. If it is blocked, this area will not be getting the supply. So if it is having collateral, then it means this blockage of this will not do any wrong because this will be operational. So now this branch will supply this area. Okay, but normally it doesn't remain active, only in such emergencies. When a particular area is infarct means when the blood supply is totally closed, either because of thrombus, formation of blockage by a thrombus, blood clot, or because of atherosclerosis, total closure is there, then a particular area will be devoid of. So what will happen to this? That area will be going to be rotten. So before it is rotten, now various collaterals, anastomotic channels will be formed to save that area. So only during such emergency they will appear. These collaterals or anastomosis channels will be formed to save that part. If it could not be, suppose it is happening in a larger, if it happens in a larger, then it may not be possible. So after 72 hours, or in that case, the patient may die. Okay, since larger area is involved. So these collaterals, these collaterals may come from extra cardiac sources. They may get collateral from, suppose, left coronary artery. They may get collateral from right coronary artery. But these are from within the heart. But outside the heart, there are some arteries. From those arteries, they can also get collaterals. What are these? These are vasa vasorum. Vasa vasorum of aorta. aorta, aortic wall, they are also having musculature. So that musculature also needs blood supply. These vessels are called vasa vasorum. These vasa vasorum of the aorta, vasa vasorum of the pulmonary arteries, and internal thoracic artery, and also bronchial arteries and phrenic arteries. Phrenic arteries, the arteries that supply the diaphragm. So from them, from those arteries, the coronary vasculature, coronary arteries can get collaterals. Okay, but these are not sufficient. These will be supplying their, they will be contributing, but their contribution is not enough. They will be contributing during the time of emergency, so that the affected area get recovered within a period of time. See, these are the anastomotic channels. Red combination is there. Normally what is there? Blue and red means arterioles, arterial end capillaries, then venous end capillaries originate. So this sort of normal in other system, this sort of capillary formation, when arterial end from the arterial venous end is produced. Okay, so this sort of, this is the normal phenomena. But these are not normal phenomena. These are what? These are the anastomosis. But these anastomosis, though they are, these are anatomic. Anatomically these are the, but they are not functional. But when they will be functional, as I said, during emergency, during crisis. Another important factor is the dominance. Who is dominant? Either LC is dominant, left coronary artery is dominant, or right coronary artery is dominant. How you will determine this? You can determine this by this. This is what? This is PDA. Posteriorly, running through sulcus, interventricular sulcus. Who is supplying? Who is supplying this artery? Whether this is the left circumflex, and this is what? This is the from right. So if it is supplied by the both, then it is called co-dominant. And these are present in 10 to 20% people. These are present in 10 to 20. Most unlikely they develop atherosclerosis or any blockage. Okay. And if it is dominated by this, by the right, see this one, this is the dominated by the right coronary artery. So right coronary dominance, it is mostly near about 60 to 70% people are having this. And the left one, it is observed in again around 10% of people. It is very less number of people are having left dominance. So mostly there it is right dominance, and co-dominate only 10 to 20%. You understood by the dominance? This part is important for in physiology. Means special features. Sometimes you may get like this. What are the special features of coronary circulation? Or you may get questions like this. What are the peculiarities of coronary circulation? So let us discuss one by one. So you try to, there are 10, 12 to 12 points. So try to cover those points. Only just mention these points. And now I will be trying to explain these points to you. Blood flows in coronary arteries mainly during diastole. It is already explained. Or it's during systole. Why it is? Why it is during mostly during diastole? What happened? Why not during systole? Why not during systole? Who will tell? Why not during systole? Tell.
Sir, during systole, the valves get closed. Like the flaps get closed. So
The flaps partially closing the aperture of the origin of the
artery.
arteries, orifice of the arteries.
That's why the blood cannot enter.
This is one reason, part of the reason.
Another reason is during contraction, the
Ventricular muscles are compressed. So blood vessels within this myometrium, they are also compressed. So less blood will be flowing. So that's why less blood flows during systole, ventricular contraction, and more blood flows since there is no such obstruction. Vessels are dilated, so blood can easily enter through the vessels. So that's why blood flows in coronary during diastole mainly. Okay, that point you understood? Okay. Next point is what coronary blood vessels are end arteries. End arteries means they will end arterial, they will form capillaries, that's all. But formation of collaterals are not end arteries. That means it is joining with another artery. But here this arterial is not joining with any other arterial. So that's why these are called end arteries. So here you will get normally end arteries. But there are anastomotic channels. Or collaterals, same thing. Anastomotic channels and collaterals are synonymous. Same. So normally they are absent. But if they are present, anatomically if they are present, they are not functional. They become functional when the heart muscles are in crisis. There is less blood flow. There is less supply of oxygen. That means they are experiencing ischemia. So that time they may become functional. So you understood the second point? Next, third point is high capillary density. If this arteriole produces 100 capillaries, so this may supply more blood to the tissues. And if this is having only 20 capillaries, it will be capable of supplying less blood. So here the arterioles are having lot of capillaries. So number of capillaries are very, very high here. And the distance between the vessels and tissues are very less. So they have to pass, oxygen has to pass very small distance. But in other tissues, there are because in between there are fluids. Because extracellular fluid. So first blood has to enter from the blood vessel, wall of the blood vessel, then into ECF, then from the ECF again into the ICF. So there is more distance, but here the distance is very less. So that diffusion of gases, diffusion of nutrients can take place in a shorter period of time. Fourth point. What is the fourth point? High oxygen extraction. One point I want to be clear. We say arterial blood are oxygenated blood and venous blood are deoxygenated. What does it mean? Does venous blood is devoid of oxygen? Then why we call it deoxygenated?
There's more concentration of carbon dioxide and
small concentration of carbon dioxide. More concentration of carbon dioxide. No, I'm oxygenation. Deoxygenated, oxygenated. There is no question of why we are pulling carbon dioxide here. No need of pulling.
it is oxygen.
We are concerned with oxygen.
Less oxygen.
in comparison to arterial blood. That is the point. That is the point. Okay. So, when arterial blood goes to the tissues, some amount of oxygen goes to the tissues. Not whole. Partly goes. Partly goes. And remaining part is retained within the venous blood. Okay? How much it goes? How much blood? Okay, next another question. I think everybody knows it. Everybody know it. What is this question? Question is, how much hemoglobin you are having in your 100 ml blood? Means, what is the percentage of hemoglobin in your blood? And with unit he also said 14.2. What is the value?
33.33% in 100.
Percent? What are you talking about?
So you asked the percentage.
Hemoglobin percentage. Hemoglobin percentage. Normally you are having 100% of hemoglobin. 14 gram per 100 ml means you are having 100%. So why you are telling it 33%?
I thought the concentration of hemoglobin molecules in 100 ml of blood, I thought.
No.
We thought the question was like how much quantity.
Hemoglobin, how much hemoglobin, I specifically told how much hemoglobin you are having in your 100 ml of blood.
That's 14 to 16 in grams.
Okay, let it be 15 gram percent, means 15 gram per 100 ml. Now next part of my question is, how much function of the hemoglobin, one of the function of the hemoglobin is to carry oxygen. So every gram of hemoglobin carry certain amount of oxygen. What is this amount?
13.8 ml.
1.34 milliliter. 1.34 milliliter of, if the hemoglobin is fully saturated. Fully saturated means every molecule have 4 iron, one remains outside of the molecule, so that it can bind with one molecule of oxygen. One molecule of oxygen binds with hemoglobin, then what happens? A structural change take place. The other molecules come out. Other heme molecule become exposed. Now they are available for binding with oxygen. So that means by this its affinity is increased. So at the most maximum it can bind 4 molecules of oxygen. So that means it is now 100% saturated. So if hemoglobin is 100% saturated, so 1 gram of hemoglobin can carry 1.34 milliliter of oxygen. Now if your blood is having 15 gram of hemoglobin, then 100 gram of your blood can carry certain amount of oxygen. How much it is? That means what will be the content of oxygen in your arterial blood? That means 15 gram into 1.34, because your 100 ml blood contains only 15 gram, and this will only carry oxygen. So how much it will carry? 1.34 into 15, how much it comes? Calculate how much it comes. You can use your calculator. Fast. Do it fast. Okay. If your blood is having 12 gram hemoglobin,
16.16.
so you can see less hemoglobin means less oxygen you can carry. More hemoglobin, more oxygen you can carry. 15, if I consider it as a normal 100% hemoglobin you are having, then only near about 20 ml of oxygen you can carry, 19 to 20 ml. Okay? Now the arterial blood is coming to the periphery, to the tissues. Now tissues will take up some amount, depending on its need, it will take up oxygen. Okay? Then this blood will be entering into the venous system. Now the venous blood will be having the oxygen. How much oxygen? It carried 19 ml or 20 ml. It gave certain amount of blood oxygen to the tissues. Then you have to subtract this. Tissue normally 4 to 5 ml. Normally 4 to 5 ml it extracts. Then how much will be retained in the venous blood? 20 or 19 minus 5? 14. So in the venous blood, oxygen content is 13 to 14 milliliter per 100 ml. Okay. Now see, same arterial blood, when goes to the myocardium through coronary arteries, myocardium will take up oxygen. And this arterial blood is having 20 ml of oxygen. Now when it entered in the venous system, now I can see only 5 ml of blood is there, 5 ml of oxygen is there. 5 to 6 ml of oxygen is there. So where the rest of the amount of oxygen gone? It has been taken up by the myocardium. How much it has taken? 20 or 19 minus 13. This much about is taken. So what is the remainder amount? 4 or 5 ml of. That means the fourth point, it is having high oxygen extraction from arterial blood. Because of high extraction, its venous blood contains very, very less amount of oxygen in comparison to venous blood that is coming from other part of my body. Is that clear to you now? The venous blood coming from my other tissues is having nearly 13 to 14 ml. Whereas venous blood that is coming out of the cardiac muscle, there is only 5-6 ml. That is, most of the oxygen is extracted by the ventricular muscles, by the myocardium. So that means it is having high oxygen extraction capacity. Is that point clear to you? Right? Okay. Next point is CBF. CBF means coronary blood flow. Blood flow through the arteries. Coronary blood flow is adjusted according to the metabolic need of the myocardium. Simple. Metabolic need means I started contracting these muscles. So these muscles require more and more ATP. Where from this ATP will come? From the oxidation of the nutrients. So there are different metabolic paths to derive ATP. That means in the muscle metabolic activity is increased. So more contraction, more metabolic need, more oxidation, more need of oxygen. More need of oxygen, more supply of blood. So these are interrelated. When there is cardiac activity is increased, the muscle will require, cardiac muscle will require more oxygen. To supply more oxygen, there should be more supply of oxygen and nutrient, more supply of blood. Means you have to increase your coronary blood flow. How this is made? How this is made? Coronary circulation, coronary blood flow is having its own regulation. Own regulation means if circulation is increased, it can bring it down to a normal range. If it falls below, becomes very low, then it can increase to the normal range. So this is called the auto-regulation. So coronary circulation can auto-regulate its flow, blood flow within a range. What is the range? 60 to 140, 150 millimeter of mercury pressure. If blood flow is reduced less than 60 millimeter of mercury pressure, it will increase it. If it goes beyond 150, 160, it will bring it down. If it goes beyond near about 200, it will bring it down to normal range. So that capacity is having, and this is called auto-regulation. There are two methods of auto-regulation. Two methods. One is myogenic theory. One is explained by the myogenic theory. Another is explained by the metabolic theory. Okay, what is the myogenic theory? When perfusion pressure means blood pressure, pressure within the vessel, here vessel means coronary vessels, is increased, its diameter will be increased. When pressure is increased, diameter will be increased. And if diameter is increased, all the vessels are having a muscular coat, smooth muscle coat, they will be stretched. When these are stressed, they reflexly contract. When these are so stretching, will initiate contraction of the smooth muscle. So contraction of the smooth muscle will minimize, will lower the diameter. So diameter of the blood vessels. So initially what had happened? There was increased pressure, increased perfusion pressure. So that's why it was dilated. Now I am to bring it down to normal. How I will do it? Myogenic theory says when it is expanded, reflexly the muscles will be contracted, thereby it will be narrowing the diameter, then flow will be coming down to the normal range. This is the myogenic theory. You got it? Right? Okay. Then the metabolic theory. If I minimize the supply coronary circulation, reduce the supply of coronary circulation to the muscles, now what will happen? That muscles will get less oxygen, more carbon dioxide, more production of hydrogen ion, more ADP, ATP, more adenosine, more lactic acid. So there will be accumulation of these metabolites. And interestingly, these metabolites are having vasodilator effect. When these metabolites, I mentioned these metabolites, when these metabolites are, why these metabolites deposited? Because of low flow of blood. Low flow of blood means low supply of oxygen. Low supply of oxygen means there will be accumulation of metabolites because in the cardiac muscle there are a lot of metabolism is going on. So since activity is reduced, previously there were a lot of activities. Now metabolites has been accumulated. Now these metabolites will cause vasodilation. So now blood flow will be increased, and these metabolites will be washed away. So blood flow is increased, and since the metabolites is washed away, so no further dilatation will be occurred. So in this way, you got the points? What is the point? What happens when blood flow to the myocardium is reduced? This will cause less supply of oxygen. Less supply of oxygen means what? Less supply of blood. Less washing of metabolites will be there, so metabolites will be accumulating. When these metabolites accumulate, and what are the metabolites? One is reduced oxygen, increased carbon dioxide, increased lactic acid, increased ADP, increased ATP, increased ADP, increased adenosine. So these metabolites are having the property of causing vasodilatation of the blood vessels. So now the blood vessels will be dilated, more blood will be flowing. My intention was to increase the blood flow. Initially it was less. So because of the metabolites, accumulated metabolites, blood flow is increased. If it remains there, the further increase will be there, but it doesn't happen. Why? These are with the increased flow, that metabolites also washed away through the venous blood. So no further dilation will be there. That is how autoregulation of coronary blood flow is maintained. So what do you mean? If the question comes, how? Explain the autoregulation of coronary circulation. So we will be explaining two theories. One is myogenic theory and metabolites theory. Okay. See, regulation is mainly by metabolites and by myogenic mechanism. It is explained. Next, anatomical anastomosis. I have explained it. Normally it is there, but it is not functional. When there is a need, then it will become functional. And coronary vessels are susceptible to degeneration and atherosclerosis. Degeneration means when they become narrowed because of atherosclerosis or partial obstruction by thrombus. What will happen? Or vasospasm. So there may be, what will happen? This terminal end of the vessels may degenerate or form atherosclerosis. Okay. First here, see, it receives 4 to 5% of the cardiac output. Okay, this point I need to be explained. Forget about this. Now listen to me. Your heart pumps blood into the circulation. The ventricles particularly. When ventricle pumps or contracts, certain amount of blood, with each beat, certain amount of blood enters into the aorta or in pulmonary arteries. This amount of blood ejected by each ventricle in each beat is called stroke volume. What is stroke volume? Tell.
Pumped by the ventricles. Blood which is pumped by the ventricles with each beat.
Yeah. What is this amount?
I think so. 70 ml.
Very good. It is 70 ml. Normally it is 70 ml. Tell one beat 70 ml. This side also will beat. The arterial also eject 70 ml. So that's why our definition is amount of blood ejected by each ventricle during each contraction is called stroke volume. The amount is normally 70 ml. It varies. This is the mean value. Another term we use, cardiac output. Do you know what is cardiac output? Don't know. Who can say? Who can tell? Cardiac output, we generally expressed in two terms. By two terms. One is stroke volume. We came to know what is stroke volume. Another is, he said, amount of blood ejected in 1 minute by each ventricle. That is minute volume, minute output. One is by stroke, another is during each minute by the ventricle, by each ventricle. How much blood you will be ejecting? You don't answer. How much blood you will be ejecting in 1 minute? If it is 70, your stroke volume is 70 in 1 minute. How much blood you can eject?
4900 ml. 72 into 70 ml.
Why 72?
Beats per minute.
Yes. In 1 minute, your heart will be beating 72 times. Each time 70 ml. So into 72. If it is 80, then 70 into 80. If your stroke volume is 90, 90 into 72 or 90 into 75 or 90 into 80. So if your heartbeat increases, cardiac output will be increased. If your stroke volume increases, cardiac output will be increasing. Is that clear? Okay, fine. Now we are coming to this coronary peak. Our normal cardiac output is then 5 to near about 5 liters. Near about 5 liters. Out of these 5 liters in 1 minute, out of these 5 liters, the 300 gram, our weight of the heart is 300 gram. It consumes 225 ml. How much? 225 ml per minute. Means its consumption rate is very high. If you express the other tissues, how much it consumes per 100 gram, and heart per 100 gram, how much it? Much more by the heart. Because our heart continuously working without any pause, কবে start হয়েছে and it will end when we will be dying. Okay, that's why its activity is different from our other tissues, other cells. So it receives 4 to 5% of the cardiac output, which is 225 to 250 ml per minute. So that point you understood? Okay. Blood flow to the left ventricular wall is greater in diastole. That is also we have explained. Subendocardial layer is compressed maximally. It is also I have discussed. Subendocardial layer is compressed maximally during systole and therefore prone to suffer from ischemia more than the other layers. Convinced? Right? It has been explained. Oxygen consumption is very high. 70 to 80%. So AB differences, it is also been explained. AB difference we have seen in cardiac muscle, AB difference arteriovenous difference of oxygen. In heart it is very high, very less, whereas in case of other tissues it is 20 ml, 19 ml minus 14 ml or 15 ml, and here it is 19 ml to 4 ml, 5 ml. So difference is high here. And blood flow is regulated mostly at the local arteriolar vasodilation. The blood way actually, they can control the vessels. The vessel itself can control. We said in the myocardium, metabolites are accumulated, so they will be dilating. So it is the function of the small arteries, not the main arteries. They are not affected. They are not affected by the central nervous system. They have got, central nervous system has got influence on coronary circulation, but that is indirectly. Because parasympathetic nerve, vagus nerve, the vessels are supplied minimum. The vessels are having minimum supply from the vagus nerve. So it cannot affect so much the coronary circulation. So parasympathetic nerves usually what it dilates the blood vessels. So if it is not having so much of supply to the vasculature, so it cannot, stimulation of brain stem will not cause vasodilation. Whereas stimulation of sympathetic nerve, it is having normally vasoconstriction, so it can increase the blood pressure, it can increase the flow, but decrease the flow, but it is also having minimum role here, but it is having indirect role. How? Sympathetic stimulation. If sympathetic nerve is stimulated, what happens to our heart rate? Increase or decrease? Increase or decrease? তুমি যখন ভয় পাও, when you become afraid, that is your sympathetic nerve is stimulated. So that's why your heart rate is increased. So if your heart rate is increased, okay, another, you said our normal resting heart rate is 72, somebody said 75, somebody said 80. Okay, let it be 75. How much? 75 beats per minute. How much time one beat will take? One beat will take some time. If your heartbeat is 75, then how much time one beat will take?
70 by 60. 75 by 60.
60 by 75. 0.8 second. How much? This is the cardiac cycle length. Normal cardiac cycle length. Now you see what happens to this 0.8 second. If I increase the heart rate to 100, আমি বাড়িয়ে দিলাম heart rate from 75 to 100. Now what will happen to this cycle length? It will decrease. It will, so increase in heart rate, there will decrease in cardiac cycle. Cardiac cycle means what? There is systole and diastole. Since length is reduced, time for systole and diastole will also be reduced. Now, time for diastole is reduced. Time for diastole, well, we know maximum flow occurs during diastole. Now there is less filling time of the ventricle. Filling time, then only it has to be filled, no? But time is less. Less blood will be entering and less blood will be coming out. So flow will be affected. So increase in heart rate will also cause changing flow. This regulation, we said 80, 60 to 150, 140 millimeter mercury pressure, they will try to maintain the cardiac flow within this range. And this is done by the vessels itself, mainly by the vessel itself, not by other, mainly by this vessel itself, one by myogenic theory and by metabolites. And during metabolism, other tissues, muscles, they utilize carbohydrate mainly. But cardiac muscle utilize mainly free fatty acid. 70% of the energy comes from fatty acid. Okay? It can utilize lactic acid also. Directly it can use lactic acid. Whatever lactic acid I am producing in this, if these are washed away into the blood, the cardiac muscle, okay, no problem. I can digest them, no problem. I can utilize them. Degree of damage to the heart muscle is determined to a great extent by degree of collateral circulation that is already developed, so that or that can develop within minutes after the occlusion. Means what? What is the meaning of this? How much the heart muscle will be damaged? It will depend on how fast you could develop collaterals. It has to develop within how many hours? Within few minutes. It start to develop within the anatomical anastomosis, but that was not functional. Now they will become functional to recover those affected area. So degree of damage, it will depend on degree of collateral formation. Coronary blood flow is phasic, more during diastole and minimum during systole. I have already explained. Dominance I have explained. Coronary blood flow is closely coupled to cardiac metabolism. If more metabolites, because of more metabolites are produced, there will be dilatation. And if less metabolites are produced, there will not be dilatation. They explain. See. One of the important characteristics, last point, one of the important characteristics of coronary circulation is the muscles, cardiac muscles have phasic circulation. Means during systole, one type of flow, during diastole, one type. We have already discussed that point. And CA, the amount. Normally we said it is 225 per minute. Okay, so this is the 225 when before systole. We know during systole flow reduces, so reduction is there. So reduction, the flow may become below 100. At the initial part of the systole, it may come down to below 100, say about 90. Then it again gradually rises to about 100 ml. Then what is happening? Diastole. Now it is relaxing. Now blood vessels will become dilated, so flow will be increasing. So what is C? During systole flow is reduced, during diastole flow is increased. Again, at the end of the diastole, again 228, diastole is ended, so here and this value are same, 225. Again the cycle will continue. So we have said this is called phasic blood flow, and these are the reasons of phasic blood flow of coronary circulation. You can also, this question may also come. Autoregulation, phasic flow. Explain the phasic flow during systole and diastole in ventricular muscle. This is particularly observed in left ventricle. Right ventricle, it is white. This is shown by left ventricle. But right ventricle, it is not like that. Because left ventricle wall is thick. Compression will be more here. In right ventricle is thin. And left ventricle has to produce more force. Here it has to produce less force. So less contraction. So least effect will be there in cardiac outflow, coronary blood flow. So this is the difference between left ventricular blood flow and right ventricular blood flow. Already I explained physical means it will depend on physical means blood pressure. If pressure is increased, reflexly because of autoregulation it will come down. Heart rate, I have also explained, if heart rate is increased, filling time is decreased, so flow will be affected. Chemical, already explained some metabolites. Accumulation matter, they can dilate it. Neural, I said ki vagus sympathetic has minimum effect. And hormonal, only two hormones, thyroid hormone and Antidiuretic hormone, vasopressin. Vasopressin reduces and thyroid hormone increases. Okay, why thyroid? Thyroid hormone, thyroxine increases the metabolism in the cardiac muscle also. As a result, what will happen? More metabolism, more activity, more blood flow. Heart rate, metabolic effect, all these factors, nervous factor, direct effect, indirect effect. Direct effect, minimum, indirect effect from increasing heart rate. Hormonal factor, thyroxine increases CVF, coronary blood flow, vasopressin decreases CVF. This is one part. The last part, very important. Go through it. Distension of the stomach, gas, or it is pain. Here you are experiencing, this is because of gas only. So you have given some antacid and after few hours patient died. Why? It is not because of acidity. There was distension. But this distension caused reflex vasoconstriction of the coronary blood vessels. Means decreased blood flow, inadequate oxygen supply, narrowing of blood flow, inadequate oxygen supply, inadequate supply of nutrients. So there is blockage, there is attack. So you misdiagnosed. So it may happen. This is distension, gas. No. At the same, you have to be very sure he is not experiencing what? Angina pectoris. So there should be, you are able to diagnose, differentiate between the two. So distension or in the epicardial pain may not be always because of this, it may be because of angina. Coronary autoregulation I have explained, autoregulation explained, tissue metabolic theory, and now the applied aspects. Already I have discussed when there is less supply of oxygen, narrowing, less supply of oxygen, and you will be experiencing angina. So angina is a pain. Why this pain? Because of accumulation of these factors. P factor, lactic acid, histamine, K and kinins. These are the reasons for generation of pain during angina pectoris. And why? What is the cause of angina? Narrowing of the blood vessels, coronary blood vessels. Why narrowing? Because of spasm. It may happen because of spasm or atherosclerosis or blockage, partial blockage by blood clots. Myocardial infarction, total blockage. Total blockage of the blood vessels. So certain area will not be getting. The last point, it may happen by, it may complicated by fatal ventricular fibrillation. Ventricular fibrillation means what? Rapid contraction of the ventricles. Rapid but incomplete contraction. So there will not be any ejection of blood. Only partial contraction will be there. This will hamper the systole and diastole. No systole cannot take place properly, diastole cannot. So if it is not stopped immediately by defibrillator, then or some drugs, then the patient may die. So this myocardial infarction may initiate ventricular fibrillation. So this ventricular fibrillation may further aggravate the problem.
Sir, what is the full form of VT drugs? VT drugs.
That you will be learning. Not you are not you will not be managing the patient now. This you will be learning during third phase. This is the normal blood vessel. This is atherosclerosed. So lumen is narrowing. So it may completely block. This atherosclerosis may completely block. Or when this is roughened, the surface is, by this surface become rough. So when the platelets flow through this, the platelets are very fragile. So these platelets can be broken in presence of the blood vessel. So there will be initiation of clotting. So a clottus or thrombus will be formed here. So it will cause complete blockage of the heart vessel. The blockage may be here, blockage may be here, blockage may be here, blockage may be in the side. So treatment for this, what are the treatment available for such problems? One is first angioplasty has to be done. Through angioplasty, we can diagnose where the problem is. Then, so during angioplasty, we have inserted one catheter. So this catheter is having other applications also. It can inflate one balloon, small balloon at the tip. So this will go near to the blockage and inflate the balloon. So the compressed vessel will be dilated. Again it will proceed. Again it will deflate and then inflate. So for next area will be dilated. Again it will go forward. So again this way it can be dilated. But this dilation is not permanent. So to make it permanent, what is done? One spring is inserted there. So this is having another thing, we have a spring is also there. So blockage is covered, dilated. Now this is having one spring. So it will release the spring, then the catheter will be taken out. Now the vessel is now patent. Previously when it was balloon angioplasty was not there. So at that time what had to be done? So we had to take out another vessel. Suppose blockage is here. So this is the artery. So one end of this vessel will be attached here. Another end will be attached to the other end in between the blockage. Now blood will be bypassing this area to the later part. So that was the earlier process. Now this is not been done, and the process is now a balloon angioplasty. These are the atherosclerotic part, blockage part. So this is the catheter. This is inserted. Balloon is inflated. Then here one spring is. This image is not there. So one spring is kept there. So now it will remain intact. Okay.